हाय फ्रेंड्स, वेलकम टू क्लासेस बाय लैब डॉक्टर। आज के क्लास में वी विल सी व्हाट आर द टेस्ट विच वी यूज टू डिटेक्ट bilirubin in the urine. So you all know when we do a routine urine microscopy, you will never see bilirubin in the urine in a normal or a healthy individual. The urine bilirubin is negative. So whenever a patient sometimes complains of yellowish discoloration of the sclera or his skin or his nails, patient is having pain abdomen, he's having loss of appetite, there is weight loss, there is nausea, vomiting, he's feeling very tired, उसमें डार्क कलर का यूरिन पास कर रहा है, यूरिन बहुत ही येलो बोल रहा है, so that time the doctor will tell the patient to get a urine test done also to see if there is bilirubin in the urine. So when do we call bilirubinuria? Whenever there is bilirubin in the urine, and this bilirubin has to be conjugated bilirubin. If it is unconjugated, वो यूरिन में नहीं रहेगा, क्योंकि unconjugated bilirubin जो है वो वाटर में soluble नहीं रहता है. तो अगर यूरिन में उस bilirubin को आना है तो उसको water soluble होना चाहिए. So that is why this will be conjugated hyperbilirubinemia. In a healthy individual, we will not see bilirubin in the urine. अगर in an healthy individual we are seeing bilirubin, उसको तो we have to suspect whether it could be something related to abnormal liver function, या तो there is some problem with the bile ducts. So these are the causes for hyperbilirubinemia. So it could be either because of impaired hepatic excretion, there is some problem inside the liver wherein the liver is not able to excrete this properly, the bilirubin properly. It could be because of hereditary disorders like Dubin-Johnson syndrome, Rotor syndrome, or it could be cholestatic jaundice of pregnancy, or it could be acquired disorders like hepatitis, viral hepatitis, drug-induced hepatitis, or it could be alcoholic liver disease, sepsis, biliary cirrhosis, or it could be an external extrahepatic biliary obstruction which will cause hyperbilirubinemia. For example, it could be gallstone, it could be infection, it could be a pancreatic head malignancy, it could be sclerosing cholangitis, it could be inflammation in the pancreas. All these can lead to increased bilirubin, increased conjugated bilirubin in the urine. So what are the tests which we use to do, or which we use to find out the bilirubin in the urine? One is the most commonly done test is our reagent strip method. We also use the Fouchet's test, and there are also tablet methods to detect urine bilirubin. So first let us concentrate on the reagents test. So direct bilirubin is not detectable in the urine of a healthy individual. So whenever we do a reagent strip, we usually give it as small, moderate, large, or negative. When we say small, the about 17 micromole per liter of bilirubin is present. When we say it is large, it is around 100 micromole per liter of bilirubin which is present in that urine. So what is the principle of this reagent strip method? So in the reagent strip method, what we do is, there is a chemical called as diazonium salt that reacts with the bilirubin which is present in the patient's urine at an acidic pH to produce a red azo dye. Okay, and that is what will give the color as reddish violet color. So the intensity of this color will depend upon how much the bilirubin is present in that urine. So basically it is a reaction with the diazonium salts. So sometimes you will get the false negative results. The patient is having bilirubin, but still the result will be negative. Suppose if there are urinary nitrates, or if the acidic urine, or if the pH of the urine is very less, if the patient has been using antibiotic, or whenever there is decreased intestinal flora, all this can give you negative results even though the patient is having bilirubin in his urine. Sometimes you will get false positive. The patient doesn't have any bilirubin in his urine, but sometimes you will get a false positive result. Suppose if there are any dyes such as phenazopyridine or indicans or chlorpromazine, all such can give a reddish discoloration of the urine mistakenly, which we can consider that as bilirubin positive. So this is the multiple urine test strips, wherein you will see that, see, this is the bilirubin which we read. Usually it should be negative, and depending upon the color we grade it as small, moderate and large. So there is also called test called as tablet test or echo test. So this echo test, what is the advantage of this is that, so suppose if the urine is very yellow, deeply yellow colored, such things are not going to hamper the test results, and it is also more sensitive than the reagent strip method. So this is the advantage of the echo test. In what happens in Fouchet's test, here we take around 5 ml of urine and we add around 2.5% of barium chloride and mix well, and then we filter it to obtain the precipitate on this filter paper, and to this filtrate we add 1 drop of Fouchet's reagent, and the development of bluish green color around the drop indicates the presence of bilirubin. So what is the principle here? When we add the barium chloride to the urine and when we filter it, so what happens when you add barium chloride? The barium sulfate is formed which absorbs the bilirubin. So this bilirubin is absorbed onto the filter paper. So you will have barium sulfate plus bilirubin filtrate. Now you add the Fouchet solution which contains ferric chloride. So once you add the ferric chloride, the bilirubin which is there in the filtrate, it is oxidized to biliverdin, and bilirubin is oxidized by this ferric ion. So this will be biliverdin will be giving you the green color, and the oxidized product will be giving you the bluish color. So the biliverdin is greenish and the oxidized product of biliverdin is bluish. So you will get a immediate blue green color which will be considered as positive, and suppose if there are no bluish green color, that is considered as negative. So this is the Fouchet's test. There are other types of tests also for bilirubin. You have foam test, you have LUGOL's iodine test, etc. The urine bilirubin test, the significance of this is that it will usually correlate with the serum direct bilirubin. जब भी serum direct bilirubin बढ़ा रहेगा, urine में we usually see that the patient will be having bilirubin, and it also correlates with the urobilinogen and also the serum bilirubin levels. What are the limitation of this test? The limitation of this test which we use to detect bilirubin are, there is one thing is that is prolonged exposure of the sample to light. अगर आपका sample light में बहुत exposure हो गया है, that time the bilirubin can get oxidized. And also remember that this test only measures direct bilirubin and it will not pick up the indirect bilirubin. So there are other tests also like ICOTEST, etc., which are more sensitive form than compared to the reagent strips. But you should remember that whenever you are interpreting a bilirubin test in the urine, you will have to correlate it with the patient's symptoms, the patient's serum bilirubin, his direct bilirubin, indirect bilirubin, liver function test, etc. So it has to be interpreted in correlation with his liver function test and his clinical symptoms. So when we do a dipstick urine analysis, you should normally get bilirubin as negative and urobilinogen is positive, or it is normal. Normally it is seen in the urine. So this is what we call it as normal. So what happens in biliary obstruction? अगर obstruction to bile flow होता है, so what happens? There is an obstruction, so the bilirubin will not be able to enter into the intestine. अगर enter ही नहीं होगा तो urobilinogen तो form ही नहीं होगा, तो urobilinogen will be negative, and because there is an obstruction, the conjugated bilirubin level will be increased, that will spill over into the urine. So the conjugated bilirubin what is there, that will be positive in case of obstruction. In case of an hemolytic disease, what happens? There is increased destruction of the RBCs, and whenever there is increased destruction, there is increased production of conjugated bilirubinemia, and that goes into the intestine. Increased amount of urobilinogen is formed, so that is why urobilinogen will be increased in case of hemolytic disease. Whereas in case of hemolytic disease, the bilirubin will be negative because liver is perfectly fine. The liver is able to take the load and it is converting all the unconjugated bilirubin into conjugated bilirubin, and it is excreting it in the urine. So you will not find any bilirubin in the urine in case of hemolytic disease. So what happens in hepatic disease? In hepatic disease, you might get the bilirubin as positive, because in case of hepatic disease, agar there is some problem with the liver may not be able to completely excrete it into the post bile ducts. So some amount of bilirubin might come inside the urine. So you might get positive. Whereas in case of an hepatic disease, what happens to urinobilinogen? Because the liver is not able to conjugate it and it is not able to send it. So the amount of bilirubin which is entering the bile duct or the intestine is very less, and hence the urobilinogen will be not be seen in the urine. So this is how we differentiate whether it is a biliary obstruction or a hepatic disease or a hemolytic disease with the help of bilirubin and urobilinogen. So remember always that in the normal urine, bilirubin should be negative and urobilinogen will be always positive. That is normal. In case of a biliary obstruction, there will be bilirubin which is positive, and in case of hemolytic disease, there is urobilinogen which is increased. But remember that no normal urine sample in a healthy individual will contain bilirubin. If at all bilirubin is present, it indicates there is some problem with the liver or the biliary duct. So that has to be investigated further. How will we investigate further when we see a bilirubin in the urine? We might have to do a liver function test. We might have to see his AST, ALT, GGT, direct, indirect bilirubin. We might have to do the markers for alcohol, viral hepatitis. We might have to do the markers for autoimmune hepatitis. We might even need an ultrasonography. We might even need ERCP, etc., to see the situation, to see the ductules, etc. And then we can come to a conclusion to find out what are the causes for conjugated hyperbilirubinemia. So when we narrow down the causes for conjugated hyperbilirubinemia, which could be because of an hereditary disorder to an acquired disorder to a malignancy to an infection, we can pinpoint the cause for conjugated hyperbilirubinemia and its excretion in the urine. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.